Good day, everyone. We will be discussing regarding the practical aspects of glue used for endoscopic glue injection for the fundal varices. The slides were prepared by Dr. Arjun, and I had modified the slides for the purpose of video recording. And I'll be discussing regarding the details about glue in practical aspects. Video about the procedure will not be shown in this, but it will be more about theory relevant to the practical steps. Regarding the glues, there are different types of glues available. Among the glues, the most important glue is what we commonly use in clinical practice is the N-butyl to cyanoacrylate. So the principle is that when this glue comes in contact with blood, this glue will polymerize and instantly it will form a exothermic resin-like complex material. It will form a hard acrylate cast will be formed inside the varus, and that will cause mechanical obliteration. Other glues which can be used are methyl cyanoacrylate, it is not used, 2-octyl cyanoacrylate, isobutyl cyanoacrylate, it's just for exam purpose only. Why bands are not used for fundal varices? Because in fundal varices the mucosa is very thick and the varices is seated deep submucosally. So bands will not be helping out in fundal varices. The glues was first described in 1986 by Sohendra and et al. There is something known as lipidol. We should remember about lipidol also. Lipidol is not a glue, but lipidol is a diluent. It is used instead of distilled water, and it is a radio opaque contrast material. Advantage is that if you use radio opaque contrast material lipidol, it will slow down the polymerization. So what you get is you will get some time for the process for injection. Otherwise, if it is so fast, the glucose formation will become very much hyperactive, very much fast, and you will not get time for even jiggling the catheter. So lipidol will slow down the polymerization. You will get some breath time while you are doing this glue injection. Second thing is that when you take a photo or fluoroscopic image or a X-ray after the glue injection, lipidol will increase the fluoroscopic visibility. So post glue injection, if you suspect embolization, if lipidol was added along with the glue prior to the injection, that will actually help us to identify it properly. So lipidol, but I don't think all centers lipidol is used. Distilled water is more commonly used. Indications for glue injection is GOV2 and IgV1. In GOV1 we know EVL will do. In IgV2 glue is not going to help. If the patient is having active bleeding, in that case only we use this glue injection. The other indications are if we have a large varus which have not yet bleeded but it is having high risk matter for bleeding is in that case also we can use EVL glue injection. So what high risk matter for large varus which have not yet bleeded will be discussed in next slide. Then EVL fails, we can use glue injection in esophageal varices. In post EVL ulcers also we can try using glue injection can be used. And the complications for use of using glue is also important. Rebleeding can be there, especially if you inject the glue only in the mound, only in the top part of the varus instead of injecting it in the edge. There can be rebleeding. Ulceration, post injection ulceration can be there. Then needle sticking into the varus and we will not be able to pull out the needle, and like it will cause torrential bleeding. That's why while injecting we tell we should jiggle the needle so that it will not stick into the varus. And if the needle is not able to come out, it will end up in trouble. Then other complications are systemic complications, that is embolization can happen to the brain, lung or renal. Embolization can happen, especially this embolization risk is very high if the gastrorenal shunt is very large. In such cases we often avoid doing glue alone. We may consider glue plus coil or go ahead with other procedures like BRTO. And to reduce the complication, what we do is 1 ml of injection, 1 ml per injection is used rather than using high volume, and maximum only 5 ml will be used. And even combining coil with glue can reduce the requirement of glue and reduce the complication. In the previous slide, we were telling regarding high-risk features of fundal gastric varices. They are the features which tells that these varices can bleed even though they have not presented with acute bleeding. One is large size, more than 10 mm in size, or large tortuous nodular varices. Then red color signs like red veil signs, cherry red spots, or hemocytic spots. They indicate that it is an impending rupturable fundal varices. Then recent bleed stigmata like white nipple sign or adherent clot. So these features are endoscopic features. Other portovenogram features include presence of large gastrorenal shunt or portal vein thrombosis, splenic vein thrombosis, or segmental portal hypertension is there. They tell that these are varices, even though they have not bleeded now, they can end up in torrential bleeding. So it should be addressed as a primary prophylaxis measure. Then regarding the presence of large gastrorenal shunt, remember that glue alone might not work. Glue plus coil may be required, or even BRTO may be required. Some points regarding techniques of injecting glue. Videos we are not showing because this is majorly for the theory discussion. Regarding the techniques, the precaution to be taken while doing the glue injection is the people who perform should wear the goggles so that the glue should not spill into your eyes while injecting, or to your assistant's eyes. Then silicone oil the scopes and its channel so that the glue will not get blocked in the channels. Then discontinue the suction. This is very important. While you are performing the glue injection, the suction tube should be removed. Otherwise what happens is we inject the glue, and if the suction is there, unknowingly or unknowingly we click the suction, and it can cause aspiration of the glue into the suction channel, and it can block the entire channel and spoil your glue, spoil your scope. So suction channel should be removed. Suction should be disconnected from the system. Then maximum in a sitting we can use actually maximum 5 ml glue only. So take 0.5 ml glue in 10 syringes, and also take 3 ml of distilled water in 10 syringes, so that glue can be injected. 1 ml 1 ml of glue can be injected, and distilled water if needed can be injected. And 21 gauge injection needle, 21 gauge injection needle is used for this. So what we use is actually 21 gauge glue injection needle is the, of which discussion will be in further slides. Then first we have to flush some distilled water as a primer of about 1.5 to 3 ml into the varices, so that it will make sure that all the scope is clear, the injection needle is clear. And after that 0.5 to 1 ml of glue is injected into the varice. The most important thing is that we should not directly inject into the topmost part, or we should not directly inject into the mount. Rather we should inject into the side of the varice, and slowly then later progress up towards the mount. Otherwise what will happen is it will initially like form a clog, and then it will torrentially bleed out. So if we start from the periphery, the entire varice will get accumulated with the glue, and polymerization will occupy the entire varice. Otherwise only the top part will get polymerized, and it can result in rebleeding. After injecting the glue, second you should flush distilled water around 3 ml quickly. We should flush and withdraw the needle immediately. It's not the catheter. Catheter should not be withdrawn, but the needle should be withdrawn. Then most important thing is that while injecting the glue, you should jiggle the catheter. So two things: while jiggling, it will allow the glue to spread properly inside. Second, it will prevent the needle from sticking into the varice. Otherwise the needle, the varice, and a complex polymerization, everything will be formed, and finally the needle will get stuck into the fundal varice, and it will become more complicated. So we should keep on jiggling the catheter. So repeat 1 ml of this glue till varice is firm. So we will have to know are we successful or not. There are two signs which we commonly tell. One is red catheter sign, and second thing is probing sign. Red catheter sign is that the injection catheter will become visible with blood or reflux of blood into it. That means the process is successful. Second thing is probing sign. Probing sign means just probe and see. If it is soft, that means we should again we should repeat it. If it is not soft, that means it's hard. That means polymerization has happened. After the procedure, we should pull out the scope with the catheter tip outside. We should pull it out, and after the scope comes out, make sure it is not pulled out. The catheter is not pulled out of the scope. Rather, the tip should be cut and removed, and then remove the catheter, and then clean the suction channel or clean the working channel with acetone. So this is a red catheter tip sign. And while injecting, make sure you inject in the edge of the or the base of the varice rather than injecting on the topmost part. Then jiggling should be continued. One thing you should understand is glue extrusion. Glue extrusion means in 30% of the people, after the glue injection is done, the mucosa will get sloughed off over the polymer cast. So It usually occur within 2 weeks to 3 months time, or it may even take 6 months of time. So if early extrusion happens, sometimes rebleeding can happen. So in the image, what you see is the extruded out glue. So if it is very large, it can result in bleeding. Otherwise, this extrusion is a natural process. So small cast only if it is visible. So what you see in the image is actually a cast. So if it is only a small cast which is visible, only a small cast is visible, there is no problem. But if it is a very large cast, that can result in bleeding. And when you redo an endoscopy and only a small cast is there and the varus is fully firm, that means this is okay, safe, and no bleeding is there. It is considered dangerous if there's active bleeding you see from this site. That means it should be re-intervened. And soft cast on probing, that means it should be re-intervened. And only partial cast is there, that is also a problematic situation. So other options we should know about fundal varices is, so previously it was only glue, but later we started using EUS glue, EUS guided glue plus coiling. The advantage is that regarding coil we'll discuss in some other video. The advantage is that when coil is combined with glue, the amount of glue required will get reduced, so that embolization risk can be reduced, and success rate is also more when we combine coil with glue. Then other options we should know is BRTO, PARTO, CARTO. BRTO is balloon occluded retrograde transvenous obliteration of this varices. So most important requirement of BRTO, PRTO, CRTO is that there should be gastrorenal shunt should be there. So before intervening any patients with fundal varices, we should take a photovenogram of this patient to know that is there a normally existing gastrorenal shunt. If gastrorenal shunt is there, BRTO can be done. BRTO can be done. But BRTO is recommended only in patients in whom first sitting it is recommended only if the fundal varices after treatment with glue injection or coiling has failed. In such cases, you can take up for BRTO. In BRTO, difference between BRTO, PRTO and CRTO is also some other discussion. The basic thing is that in BRTO, the balloon will be kept there for 24 hours. So after injecting the sclerosing agent, PRTO, a plug will be injected. So balloon need not, the catheter need not be kept 24 hours inside the patient. In CRTO, a coil is being kept. Tips can also be done in patients who fail to BRTO procedures, or if there is no gastrorenal shunt and the patient has failed to endotherapies like US coil or US glue, tips can be considered. These are some important tables like acute fundal bleeding. You can go ahead with glue or US glue. If there are high embolism risk is there, to reduce the amount of glue, consider US coil plus glue. That's why the photovenogram will tell if there is a large renal gastric shunt is there. That means embolization risk will be high. Go ahead with coil plus glue rather than going glue alone. If there is large gastrorenal shunt, the chances of success for a glue is very less. In those cases, first itself you may have to consider BRTO. But if your center doesn't have an facility for BRTO, go ahead with EUS coiling. If you fail, go ahead with BRTO. If rebleeding after glue, EUS coiling can be done, or if rebleeding after EUS coiling plus glue, BRTO can be taken up. If no shunt is present and you are not able to control the bleeding with coiling or glue, go ahead with tips. If the patient is having fundal varices with associated refractory ascites, but there is no significant HE history, tips is an option. But tips, after tips, the patient can go into HE. So those things should be considered. Then high risk encephalopathy people, that's what tips is a preferred choice. The problem, one important complication you should remember about BRTO is that post BRTO, esophageal varices can worsen and patients' ascites can worsen. This is one complication you should